All right, guys. Let me. So the lecture is what I noticed. يعني it's 66 slides, mashallah. Okay, and that's typical clinical lectures بصراحة. But I'm gonna give you يعني the main idea. يعني I don't want to spend too much time on it because في النهاية, like a lot of the concepts are يعني what they focus on in clinical is management, diagnosis, like that's what they care about from the clinical lectures. If there's a criteria, they might want you to know the criteria. And yeah, it's mainly that بصراحة. يعني pathophysiology, for example, you don't need to worry about it in this lecture. You worry about it more in pathology lectures. Risk factors too, usually they mention it in the pathology lectures, but يعني we can go over these things, okay? And anytime you have any questions, please feel free to ask in chat or just unmute. Okay. So first of all, I'm using the same PowerPoint. The only difference is that I added some notes, either notes here on the slide or in the comment section, only so that it can help you يعني, have more explanations, I guess. Yeah. And when you're studying, you can use the same PowerPoint. Yeah. Okay. So neurodegenerative diseases. So from the name, it's basically they're a spectrum of disorders that in which you have neurons undergoing degeneration, and that's the basic of the pathophysiology. You have degenerative loss of neurons, and because these disorders, there's like a wide spectrum of them, they classified them into two types. Okay, you have the cognitive disorders and the movement disorders. Okay, from their name, you can kind of guess what they hold, okay, what kind of disorders they are. So like, for example, the movement disorders, they cause movement problems. Why? Because the areas that they affect are related to, they help you with movement. For example, the basal ganglia, we know that they're responsible for inhibiting a lot of the movements that we do, okay? There are other parts of our brain that are responsible for initiating movement. So these areas, when they get affected, they cause a movement disorder, okay? And we'll talk about the details. Cognitive disorders, you have degeneration of neurons in the cortex. So they cause problems with cognition and mainly dementia. So like memory problems, forgetfulness, language, all these sorts of things, okay? This is a broad classification that you guys just need to يعني, know it as a basic صراحة. Now, general characteristics. So general characteristics, these apply for most of the disorders under neurodegenerative disorders. The first thing is that they're all spontaneous, progressive, and they degeneration of neurons. What that means is that spontaneous, they begin suddenly, okay? And progressive is that they're not stable. Once the person gets it, they just keep deteriorating, okay? Some of these disorders, they deteriorate faster than others, while others take like years to deteriorate, okay? And you'll see that once we discuss the specific disorders, which one applies to what. Okay, so that's the main thing that you need to remember from this slide. Another thing is that the clinical features of each of these disorders depends on the area affected. So as mentioned here, like there's some groups of neurons, the groups of neurons that are affected, they have functional relationships rather than physical location. So it's not just يعني, okay, these cells are affected. Why specifically are these group of cells affected? It's because they're related by function, not by location, not because they're all just beside each other, they get degenerated, no. It's more related to their function, that they all have this specific function, so they end up degenerating. That's an example. To give you an example, actually like Parkinson's disease, okay? In Parkinson's disease, what's the area that's affected? Can you guys tell me? This should be يعني, easy, since I'm pretty sure you took it in pathology. Substantia Nigra, yes, okay. So, and the Substantia Nigra, what do we know about it? What are the neurons in the Substantia Nigra, what are they responsible for? Dopamine release, exactly. So you realize, in Parkinson's, what neurons are affected? It's the neurons that secrete dopamine. So they're all related with this function. And because of that, because these specific neurons are affected, it ends up with a motor disorder where you have movement disorder, where you have like uncontrolled movements or movements that you like resting tremor. We'll get more into the details of the clinical features, but what I just wanted to explain here is that it's more related to the function of the neurons rather than the physical location. Okay, not just because they're all beside each other, they're going to get affected. No, it's because they all have a similar function. To demonstrate this, there's a picture I added here, like this, for example. You can see here in Huntington disease, for example, you have this area affected, okay? Multiple sclerosis, it's widespread, it's all over the place. It's not just in one area because they all have, what's the common feature between these cells that are getting affected? They have a similar function, okay? Same thing with Alzheimer's, okay? This is just a picture for you guys. And this is good if you guys, because I know you take pharma, actually no, I don't know, second year, I don't think you take pharma that well, صح? You don't go into deep pharma, wala, in neuro. Have you taken these drugs? Levodopa, bromocriptine, we take pharma. Okay, good. معلش انتوا شايفيتني أنا نسيت كل second year, I swear. But yeah, okay. So these drugs then are important, okay? Especially the ones that they ask most about is the idea of Parkinson, levodopa, and how you need to give carbidopa with levodopa. That's probably something you'll review in pharma, يعني. But it's something that's high yield, يعني. Okay? طيب. Okay, so as I said, the pattern of neuronal loss is selective. It affects one or more groups of neurons while leaves the others intact. And yeah, some of the diseases, they can affect both the spinal cord and the brain. Others, they only affect the spinal cord. And for example, Alzheimer's disease, it only affects the brain, okay? And that's the slide. Let's see. Okay, now underlying pathophysiology of most of these disorders has something to do with a protein aggregating, okay? So for example, do you guys know what, in Alzheimer's disease, what protein aggregates? Or proteins, there's actually two. Tau protein, okay, and? Yep, amyloid beta or beta amyloid. So and why are they accumulating? Because of inadequate, يعني, I think it was inadequate secretase activity, and we'll get to it. But المهم إنه you have this protein that is not being able to degrade. It's your body is not able to degrade it, so it ends up accumulating, okay? And that's basically a similar thing in all the diseases. Prions disease, for example, you have an abnormal protein being formed. The body is resistant to this protein. The body does not have a mechanism to degrade this protein, so it accumulates. Parkinson's, same thing. You have Lewy bodies forming. So as you can see in most of these disorders, there's some sort of protein accumulating, okay? And as we know, you should take it يعني, as a rule of thumb, accumulation of anything, any substance, whether it's lipid, whether it's glucose, is always bad, okay? So that's just something to help you with that. And yeah, so aggregated proteins are cytotoxic, but the exact mechanism of how the mechanism began, like how the protein was made, or what triggered these events, for most of the diseases, we don't know that, and that's why it's like a big area of research. But what you need to know is just that the underlying pathophysiology, the fact that these aggregated proteins are cytotoxic. And yeah, by the way, another thing, you might notice here, like sometimes there's these explanations that seem like a doctor is saying them. These are actually the doctor's transcription from, I think, my year. Yeah, from my year, I took the transcriptions of our lecture and put them here. So yeah, you might see that. You don't need to read, by the way, all over it. I'm pretty sure you have your own transcription, but it's just if you want to understand more. Okay, and basically gives you the zibda. Okay, here we have more general characteristics. So the factors that cause it, most of them is because we don't know the exact cause. They're all like genetic predisposition, environmental toxins, any of these things, these sort of vague factors that contribute to many different diseases. So just remember that they can also lead to neurodegenerative disorders. And as I mentioned, the clinical phenotype or the clinical features of the disease depend on the neurons affected, okay? That's why you have dementia with AD, but you don't have any movement disorders with AD, okay? Because the neurons affected aren't related to that. And many of the proteins aggregate appear to be capable of spreading to healthy neurons. Yeah, this specific thing is something interesting that happened in Prion's disease, and I'll leave that when we get to that slide so that you can discuss it there. Okay. So now we have these. Okay, so this here he classified it basically according to the location. So as I said, each location presents with a certain set of clinical features. If it's a cortical disease, it will have cognitive problems like memory deficits, memory disturbances, personality changes is a big thing, behavioral changes, basal ganglia, movement disorders, motor neuron degeneration, mainly muscle weakness. If it's an upper motor neuron lesion, what will it cause? This should be also an easy question. If it's an upper motor neuron lesion, spasticity, exactly. Okay. And cerebellar ataxia. These you should know them by your name by now. Okay. Okay, that's it. Okay, so these are the specific disorders under each classification. Okay. So you have movement disorders like neurotransmitter deficits, where you have dopamine deficiency of dopamine. This happens in Parkinson's. Then you have the motor neuron disease like ALS, and we know ALS, it can affect the upper motor neurons and lower motor neurons. So it's classified as a motor neuron disease because it affects specifically motor neurons, not the cells in your brain. Okay. And these, we'll discuss them. Come on, we'll discuss each one. Actually, Wernicke he doesn't discuss it here, but CNS degeneration like PICS and Huntington's, cerebrovascular multi-infarct, we need to remember that one. Creutzfeldt-Jakob, okay, and Alzheimer's. These are the ones that we'll talk about. But just know, generally which of these disorders are classified as dementias and which of them are classified as movement. Okay. It's lagging. Is it good now? Well, is it still lagging? Okay. طيب خلوني. Are you sure it's fine? يمكن it's just من عندك جود or عندك. Okay. طيب, let's continue. Okay, where was I? Okay, so aging and memory functions. So with age, there's multiple things that change in the body. We used to think that all sorts of memory changes with age. Your memory of everything decreases with time. But no, that's not the case. There's some certain types of memory that decreases with time and declines, but other sorts of memory like the semantic memory and procedural memory, no, they're stable. Okay. So I put the definition of each one here. Okay, so you have semantic and stable procedural memory. So semantic is basically your long-term memory, your understanding, your conceptual facts that you know about the world. Okay, procedural is more about how you your memory of in charge of encoding data, retrieving any sorts of procedures. Okay, it's mainly related to your senses, if I'm not mistaken. Then you have the ones that decline with age. Those are the ones you need to remember them. And honestly, if I'm not mistaken, this sort of slide, it comes usually as an MCQ, like which of the following declines with age or something like this. They don't really play around with it that much. But yeah, I put examples here, command for each one, just so you know it. And you can read through them in your own time. صراحة it's basic. Okay, now here. Okay. So normal functional changes due to aging. So yeah, obviously, if you look at an elderly person, usually what's the difference between them and someone who's a teen? Their reaction time, the way they react to anything, to their reflex, their proprioceptions, to their balance and everything, it all declines. And these are all normal, okay? But in dementia, or for example, in other cognitive disorders, they become worsened, okay? So this is why he's telling these things now, okay? Sleep changes, for example. So you need to differentiate between a patient coming to you with normal functional changes due to aging and a patient coming to you with severe signs of dementia or subtle signs of dementia. Okay, so these are some things that are normal. So it's normal for an elderly to have sleep changes, problems with thermal regulation, any posture imbalance, and these sorts of things. Okay. Now, okay, so Hina, this is another normal change that happens in our body, which is that as you age, your catecholamine system and your cholinergic system both start to decline. So catecholamines, we know catecholamines are what? Epinephrine, norepinephrine. And dopamine, for example, they're all part of the catecholamine system. Once they start to decline, your movement becomes slower, because much slower, and your reflexes too. So we know that's who's responsible for that? The decline in the catecholamine system. Cholinergic system is it's more related in your brain. So like our brain depends highly on the cholinergic system for what? For memories, for cognition. And so all these things, once they start to decline, you'll end up with benign senescence and basically forgetting. It's age-related memory decline. That's the exact definition of benign senescence, okay? They start to have memory problems and forgetfulness, okay? But you need to know that benign senescence is not due to a known disease or anything, okay? So it's something that happens with time, with normal aging. Now, pathological slowing, that's when you have Parkinson's syndrome and dementia of the Alzheimer's and all that. Okay, so as you know, Parkinson's syndrome, it's related to the catecholamine system. Alzheimer's is related to the cholinergic system. So I'm guessing that's why he put them here. Okay, so we have something called mild cognitive impairment. And some people tend to confuse mild cognitive impairment, thinking that it's the same thing as dementia. It's just an early stage of dementia. Others think that it's not, it's delirium or something. But the idea is, you can think of it as an early stage of memory loss, okay? But it's not, but most people, I'm not sure if it's most people actually, some people with mild cognitive impairment, they actually end up having their memory restored, okay? So during this period where they do have mild cognitive impairment, they do have some memory loss, some cognitive impairments where they can't do their, they can't remember certain things, or they start to have some forgetfulness, but their daily living activities, they're not impaired, okay? So that means they can still dress themselves, they can still walk around, they can still do some, the activities of daily living that are affected in Alzheimer's, okay? So they're affected in Alzheimer's, but they're not effective here in mild cognitive impairment, okay? And because of that, some people think mild cognitive impairment is an early stage of Alzheimer's, but that's not necessarily the case, because as I said, some people actually have their memory restored after getting mild cognitive impairment, while others, no, they do actually end up progressing into Alzheimer's disease after that, okay? So you just need to know that it's not necessarily someone with mild cognitive impairment, they don't necessarily end up with Alzheimer's, okay? And another thing is delirium. So delirium is like an even shorter duration of cognitive dysfunction. This is more of an acute confusion state. It's an acute state where the person is so confused. He has this hallucinations. He can't remember what time it is, what date it is. He doesn't know where he is. Okay, so this can happen from any, like, multiple causes. It can happen due to AD. It can happen due to drug toxicity. It can happen to even like thermoregulation. Okay, so it has multiple other causes. So you need to be able to distinguish between these three. Okay. And I mentioned it here, Alzheimer's disease, it's a neurodegenerative disorder, which has a progressive course. So it becomes worse with time. MCI, mild cognitive impairment, it's stable, okay? So it has a stable memory and cognitive impairment, and they can actually return back to normal with time, okay? So they don't actually end up getting worse with time, unless the person themselves is predisposed to AD, then their MCI will lead to AD, okay? So can MCI progress to something other than AD? That's a good question. Saraha, I'm not sure. Like, I haven't, from the websites that I read, most mention it in association with AD, but I can check that out to tell you. But from what I read, Saraha, I always see it with AD. So I think that's because, especially since it's a cognitive problem, so it's going to be more related to dementias. Maybe it could lead to a different kind of dementia. I'm not sure though. And yeah, so just remember, in MCI, it's kind of stable, AD progressive, delirium shorter in duration, and it's sudden, and it happens suddenly, not over time. So they'll come to you in the scenario, they say, the patient came 2 hours, or because this patient has had a confusion for 5 hours, or let's say maybe 2 days, 3 days, within days, if they want to make it tricky, yani. But so usually it's not, they won't come to you telling you, oh, this patient has had confusion for 5 months. This wouldn't be delirium, okay? Because delirium is more of something sudden that happens suddenly, okay? And yeah, that's mainly it. So MCI, as I mentioned, it's usually vague. It's late. What deficits do they have? They have memory deficits, language, attention, and visual spatial skills deterioration. but their independent skills of daily living, they're not affected, okay? Because again, it's mild. This is how they assess. So in most cases, also when they come to you with confusion or anything, you want to make sure to assess their mental status. So that's how they start with MCI. They first check for their mental status. They check for any sensory or motor deficits. They're trying to see what other causes could be causing this. Okay, so there could be any other underlying cause causing the MCI. Okay, or any exacerbating factors. And basically, look for potential causative conditions. But overall, as you can see, there's no lab test. There's no specific imaging that's specific for it. It's all just a clinical diagnosis, meaning it's based on your history and your physical examination. Okay, that's how you diagnose MCI, basically. Okay. And then these are the common causes of MCI, okay? So you can have it with due to Alzheimer's disease, you can have due to thyroid disease or cobalamin deficiency. Specifically for cobalamin, it's important, thyroid and cobalamin, they're important causes. Why? Because they're reversible. That means, if you just identify, if some doctors, they might see an MCI patient, say, okay, this is AD, and work up the patient and continue the patient as if he has AD. And even though if he actually just did a few lab tests, like a thyroid function test or a cobalamin, checking his serum cobalamin, he would have identified that it's an underlying disease that's reversible. So if he had a thyroid disease problem that's causing the MCI, he could easily reverse that. So he could easily give him some thyroid hormones, synthetic the thyroid hormones, and he would actually, his memory would be restored. He would be all as if nothing happened, okay? Same thing with cobalamin deficiency. So you need to remember, these two, they're reversible. They can be basically treated and managed, and the patient would not have the MCI would go away as if it didn't happen. Okay, so that's why you need to know that there are many underlying causes, and it's reversible. Okay, what else? So here MCI, you need to know that if they did have AD, so if the patient is a person who is predisposed to AD, then the first thing they would show is MCI. Okay, so it's basically saying, most AD patients, they come with MCI first, but not all MCA patients end up with AD. Is that clear? It's clear, صح? Okay. Then cerebrovascular diseases, because like any cerebrovascular disease that causes narrowing in the arteries, it can cause infarction in the brain, and then the infarcts, they can build up with time. They can cause MCI, or they could even eventually cause the dementia. There's a dementia caused by the multi-stroke infarct dementia. It's also caused by a similar cause. Okay. And that's the main things that he mentioned for this one, this is the table he added for, by the way, my tartib for the slides might be a bit different because I wanted it to flow with how the information is going. But it's the same slides that you guys have, okay? And here he just wanted you, when I keep saying he just wanted, that means during our lecture, okay? And what he pointed out in our lecture was that the names of diseases, and he focused on the proteins. So a lot of these proteins, I think you'll come across in pathology with the names of these proteins. So the ones mentioned, you should know them. You should associate each disease with its protein. That's important. And because as we know, we said the underlying pathophysiology for most of these diseases is aggregation of these proteins. Okay, so you need to know what the protein is. Okay, and we'll talk about now the dementias. Okay, all good up until now? Any questions? Okay, good. I'm not going too fast, صح ولا? I'm كمان hyped on coffee. Okay. So dementia, it's a syndrome of chronic diseases. It's due to progressive deterioration in cognitive function, and it's all related to neurons degenerating mainly in the brain, because that's how it causes impairment in function, in cognition. Okay, and when I say cognition, you need to think of what? Memory, attention, thinking, comprehension, language, problem solving, judgment. All these things fall into cognition. Okay, and they can also have emotional deterioration, emotional control, and basically social behavior. These are all related to personality, this can be affected too. But what's important to remember is that consciousness is never affected, okay? So in all the dementias, their consciousness is not affected. It can be affected in other disorders, but not in the dementias, okay? So 3 main words: progressive deterioration leads to cognition problems or impairments, and consciousness is not affected, okay? That's basically it from the slide. Then, so when they saw all the disorders that lead to dementia, they realized that there are a lot, so they wanted to classify them. So you have primary versus secondary dementias, you have cortical versus subcortical, reversible versus irreversible, early versus late onset. So, and from their name, you can kind of tell what it means. So generally, whenever you have primary versus secondary, that basically means the underlying pathophysiology. So a primary dementia means the problem is in the brain. So it's because of a problem in the brain, like Alzheimer's disease is a primary dementia. But a secondary dementia would be, it's due to a problem outside the brain. For example, the multi-infarct dementia. The problem is not in the brain. The problem is because of it's a vascular disease. You have narrowing because of either atherosclerosis, dyslipidemia, and all that. And that's what leads to the dementia. Okay, so it's secondary. Cortical versus subcortical, you can see this is classifies the disorders according to their location. Okay, so where the neurons are affected, if they're in the cortex or in the subcortical area. Reversible versus irreversible. So some dementias are reversible if you give them the optimal treatment. Others, like the Alzheimer's disease, for example, they're unfortunately not. And yeah, early onset versus late onset. Usually the genetic ones, the ones related to heredity, the ones that can be inherited, they're usually early onset, others are late. For example, Alzheimer's disease, usually it comes late, but if the patient has a certain syndrome, they can have it early. Do you guys know what that syndrome is? There's a certain syndrome that predisposes patients to Alzheimer's disease, so they end up having it much earlier. Yeah, Down syndrome. Good, good. That's definitely, I'm pretty sure they would ask about that, because it's high yield and they like asking about it. Okay, so now, now he just listed the diseases under each category, the primary ones and the secondary ones. As I mentioned, you can notice that all the secondary ones, they're due to a problem outside the brain. The primary ones, all Alzheimer's, Pick's, Jacob, Creutzfeldt, all of them are due to problems in the brain, okay? Here, yeah, this is the classic triad of dementia, okay? So he didn't mention it in the slide, but it's something that you should know, that aphasia, apraxia, agnosia, whenever you see these in a patient, then it's definitely dementia, or there's a high chance that this person has dementia, okay? So what does aphasia mean? It means they can't communicate effectively. So they can't understand what you're saying, or they start to forget words. Apraxia means they're lacking in the activities of daily living. If you remember, I said in MCI, you don't have a problem with this. They don't have problems with activities of daily living. But in dementia, they do, because it's more severe. Okay, so they can't walk, they can't dress properly, they can't go to the bathroom, etc. Then agnosia, where they can't incorrectly interpret their senses. So that means they can't recognize the people around them. They don't recognize when they need to urinate. So they don't understand when they have a full bladder or when they have pain. They can't interpret it that well. Okay, so remember them: aphasia, apraxia, agnosia. Okay, these are all usually cortical problem related. You find them in cortical diseases. Okay, like Alzheimer's and Pick's. These diseases, they're more subcortical, and as you can see, there's more movement disorders, dysarthria, affective disturbances, these things. That's because why? You're moved down. You're not in the cortex anymore. You're affecting areas and neurons that are more down, and you're affecting neurons that are related to movement. Okay, so that's why these diseases, they usually present like this. Okay. Then, okay, so now this is just to show you what's more common and everything. So what you need to know is that the most common cause of most common cause of dementia is AD. The second most common is vascular dementia, which, as I mentioned, is due to multiple cerebral infarcts. Then the third most common is dementia with Lewy bodies. Okay. And then you have the Pick disease, head injury. These we'll get into them here. Okay. Alzheimer's disease. Okay, so I'm pretty sure Dr. Oban gave you like a full lecture on this. So what you need to know This is basically a review of what you took in pathology. It's chronic, as I mentioned, progressive as most degenerative diseases. But as I mentioned, it's late onset. That means it appears usually in age in elderly, so above 65, except in Down syndrome, where they can even have it at the age of 50 or 40. What's the main problem? Memory, judgment, visuospatial perception. This you probably all know it. I'm trying to look for what I wanted to mention. Yeah, so as I mentioned, AD, how do you diagnose it? It's clinical. They do a mini mental state exam. They can do imaging to check the brain, everything, but in the end, it's all just clinical, and they won't get confirmation until they get an autopsy, which is basically after the patient dies. So you can only assume, and you can only have a high suspicion that this patient has AD and manage him and exclude out everything else, then manage him as if he's AD. And you'll never get the actual 100% confirmation until you do an autopsy of the brain. And what will you see on the autopsy of his brain in a patient with AD? How would his brain look like? You won't see AB protein. That's if you do microscopy, yes. Tau, okay. Wide sulci, yeah, that's around here. Wide sulci and narrow what? Wide ventricles, okay. Narrow gyri, yes, okay. And the wide ventricles give a false impression of what? They give a false, yeah, hydrocephalus. That's why many patients, if they see it, they might think, okay, this person has hydrocephalus, but it's not. It's because of the atrophy of the brain. And you need to remember, Alzheimer's disease, is the degeneration generalized or focal? This is like a key word in Alzheimer's disease. Is the degeneration generalized or focal? Generalized, exactly. That's what the whole cortex is affected, okay? It's not just a part. What disease has focal, like just a part, certain parts in the cortex affected? We didn't get to it yet, but I want to see if you guys know it. There's a neurodegenerative disease. I'm talking about one that causes dementia. Okay, it's one of the dementia in the cortical, it's a cortical problem. It affects PICs, ممكن, but there's one more specific. It affects only, it's like, okay, I'm basically using my hand to point at the area, but no, it affects two areas of the brain. You know how you have the brain, you have frontotemporal, exactly. Okay, so frontotemporal, this is more focal. So you'll only, if you look at the X-ray, not X-ray, if you look at the head MRI or CT, you'll see that the atrophy is only in the frontal and temporal areas. While in Alzheimer's disease, it's in the entire brain affected, okay? Hina, you also need to remember I think he mentioned it, that the early in pathology, he mentioned in an early disease, it occurs in patients with Down syndrome, as I mentioned, and the familial form, which is due to mutations in penicillin 1 and 2, okay? So this leads to the familial form. That means they can, patients with penicillin 1 or 2, they can, then their kids have a higher chance of AD as well. And they usually get it at an early stage, okay? Unlike someone who gets it randomly. And this is what we just mentioned. So what we said, when I said when the ventricles dilate, it gives a false impression of hydrocephalus. This is called hydrocephalus ex vacuo or vacua. I don't know how they say it, but if you see it in the exam, remember that it's due to AD, okay? Okay, now structural changes. We kind of mentioned some of these, the two proteins. We said neurofibrillary tangles and C9. Do you guys remember where they accumulate? One of them accumulates intracellularly and the other one accumulates extracellularly. Do you remember which protein? Okay, beta amyloid extracellularly, tau intracellularly. Yep. So you can see the neurofibrillary tangles, they accumulate intracellularly, and that's why they disrupt the transportation of proteins inside the cells. While beta amyloid, they accumulate extracellularly, so they disrupt the neurotransmission between the neurons. It gets affected. That's why they can't think. People with dementia, they keep forgetting, they can't think, they have lots of cognition problems because they're not able to send signals through their neurons, okay, because of these beta amyloids accumulating. Okay. Yeah, then there's increased amount of this is basically what I said. You just need to remember in AD, one of the problems they have is that acetylcholine is depleted. That's why they are given cholinergic drugs. Okay. This is the pathophysiology. Okay, so can someone explain this? Because I think you took it in pathology, so I want you guys to explain it. Yeah. Does anyone want to unmute and explain? It's a revision command for you because this could actually come as an SAQ. Not usually a clinical SAQ, but patho. No one wants to unmute. Guys, you're going to be doctors. You have to communicate. How will you communicate with your patients?
Okay, I didn't revise the lecture, but like
you can in the slide.
Yeah. Okay. So basically, normally we have like the alpha secretase enzyme and gamma secretase enzyme that will degrade the amyloid proteins.
So normally we have what?
Alpha and gamma secretase. So they will cleave the amyloid precursor proteins to get like regenerations. Okay, but in case of Alzheimer disease, there will be beta secretase enzyme and gamma secretase enzyme, but like it will degrade in another place. So that will make this receptor or this precursor protein to accumulate in certain area.
Yep.
And actually at the beginning, the alpha amyloid or the beta amyloid will accumulate. Then after accumulation of the beta amyloid, that will like, I don't know how to say it, but like will help the tau proteins to form.
Yeah, هيكون في signaling للintracellular tau proteins. The tau proteins will phosphorylate and accumulate inside. Yeah, that's right. So that's basically due to what enzyme? The beta secretase بتدخل حالها في الموضوع. It starts cleaving stuff and leaves this insoluble fragment, just like Jude explained.
And also in some sources say about gamma secretase, but I didn't find like a specific information about it, but it says in different location.
Gamma secretase has to do with it too. They cleave at a different location.
Yeah.
Okay. Yeah, that could also cause it but in the end, what's the problem?
Beta secretase.
In the end, in the end, what's going to be formed?
The accumulations of the proteins.
Yeah, it's an insoluble protein that's being formed, so your body is not able to degrade it, and that's why it accumulates.
Yeah.
Okay, good job. Okay, now these are just some slides about how it looks. This is the diffuse, these are the diffuse plaques. They're outside, they're extracellular, okay? These are intracellular. You can see the neuronal cells, they're usually not like this. They're not long like this, they're usually circular, okay? Once you see it long like this, you can tell that there's tau proteins inside or neurofibrillary tangles. This is another slide just to see it. Okay, so manifestations of Alzheimer's disease. As I mentioned, changes, he's kind of repeating a lot of the information. You have changes in cognition, communication and language, behavior, personality, all of these things, they happen in Alzheimer's disease. Okay, so this is important. Remember how I said you have some dementias and some neurodegenerative disorders. Some of them, they happen quickly and over like just a few years, the patient dies. Others, no, they're actually slow and relentless and like they take their time. Okay, so Alzheimer's disease is one of that. It's very slow, but it's progressive. It's progressive, but it happens over like a couple of years. Okay, so they can stay like this in this condition for more than 10 years. Okay, and usually the event that kills them or the reason they end up dying is because of pneumonia or infections, because of the prolonged hospital stay or something like that. Okay. And these are the risk factors. As I mentioned, he'd mentioned them here. They're also mentioned in pathology. You need to remember them. That age is very important risk factor. So if they don't, let's say they don't have Down syndrome and they don't have any mutation, what would cause a normal person who doesn't have Down syndrome or any genetic mutation, what would cause them to have AD? Just simply being old, simply reaching that age. The person is more fragile, his brain is more fragile, so he can have that. Having depression, head trauma, chronic ingestions of metals like aluminum. If family history is a very important risk factor, they're more likely to get it. Some people say ethnicity, female gender as well, and as I mentioned, Down syndrome. But the ones that are due to Down syndrome, they would present earlier. And the genetic factors, these are the ones that are due to presenilin 1 and 2, okay? Then this is AD progression. Okay, so as I mentioned, it's progressive, it's slowly progressive. So where does it usually start? It usually starts from here, from this area, okay? And then it progresses to the upper areas of the brain, okay? So it doesn't all attack everywhere at once. So yeah, so it usually begins in the enterohinal cortex specifically, just so you know. That's where the olfactory nerve ends and descends its axons. Is there anything else here that's important? With time, it spreads to the cingulate, the basal part of the frontal lobe, then inferior and medial part of the temporal lobe. Yeah. Yeah, and sometimes a biomarker which indicates AD is to see the specific atrophy in the hippocampal area. So sometimes they use, how do they know if this patient is progressing, if his AD is getting worse? They take MRI images every time and they see the atrophy, they monitor the atrophy. So first the atrophy is here, then the next on the follow-up visit, they realize that there's atrophy here. Then the other follow-up visit, they notice that the atrophy reached here now. So this is how they mark the progression. It's one of the ways they can mark it. They can mark his progression, but there are other ways that we'll get to right now. So these are the biomarkers. So as you can see here, this graph shows their proteins, the CSF amyloid beta and tau protein, they actually start accumulating much earlier than they actually present to the clinic, okay? As I mentioned, most AD patients, they come first with what? MCI, okay? Because I said MCI, it can be due to many causes, but once they have the AD, you know that it's happened after MCI. You know that they had a stage of MCI first, okay? So they usually come to your clinic with MCI first, and then it ends up being dementia as it progresses. So some of the markers are CSF amyloid beta and tau protein, but as you can see, you don't really detect them early on. There's no way of detecting them at this stage unless you go ahead and screen every single person, which I'm guessing is not very cost effective. That's why we don't have screening for Alzheimer's disease, okay? So you can measure it's just one way to measure the progression. I know as it's going to increase as they progress. As I mentioned, the MRI atrophy, which is what we mentioned in the previous slide. This is the blue line right here, okay? So it can tell you, it usually happens at the time of mild cognitive impairment, okay? Once you start seeing the MRI atrophy, you know that what I mean is during the mild cognitive impairment, you can start to see the MRI atrophy, but earlier than that, you won't see any changes in the MRI, okay? You can see changes in their CSF protein, but not in the MRI. Okay, so it starts showing at the mild cognitive impairment stage. And yeah, so all these are usually present before symptoms start to show, and then they just get worse with time. So you can use them to measure their progression, I guess. But in the end, there's no treatment that you can do. It's mainly all symptomatic treatment, okay? There's no cure, basically. Okay, so this isn't important. حتى he skipped it in our lecture. Did he explain it to you guys, by the way, this slide? Because إحنا in ours, he skipped it and doesn't really care. But I don't know, did he explain it or did he say it's important or anything? Well, none of you attended. Okay, I'm guessing none of you didn't attend. Okay, it's okay. Yeah, but it's almost the same as the one before. Okay. Yeah. It basically is. It's talking about the CSF tau and beta. I myself skipped this. Wallah, as soon as I see graphs like this, I directly skip, and it's helped me so far. So yeah, just saying. Usually the slides where the doctor stops and talks and actually points to the graph, that's when you know he actually cares about the graph. But yeah, I just realized this is recording. It's okay. Okay. So Alzheimer's diagnosis. Okay. Improbable. Okay. So sudden apoptotic. معلش, I forgot what the slide is about. Improbable AD diagnosis. If okay. So this is when to know that this patient definitely does not have AD. Okay. When you see what sudden apoplectic onset. So if they have sudden onset of Alzheimer's disease symptoms, you know that it's not Alzheimer's disease, because Alzheimer's disease, as we mentioned, it's gradual and progressive. If they have focal neurologic findings, because as I mentioned before, why I kept stressing that Alzheimer's disease is generalized, okay? So if they have focal findings, like focal findings and with focal neurologic deficits, then you know it's not AD. Just so you guys have an example, if they have hemiparesis, usually hemiparesis happens with what? Or what is hemiparesis? Do you guys know what hemiparesis is? Cerebrovascular is focal, yes. One-sided weakness, yeah, and usually in AD you don't also see one-sided weakness. Then it doesn't really affect also motor neurons. Okay, so hemiparesis is not something you would see in AD, and once you see it, you know that he has more of a focal problem affecting the motor neurons. It's too specific. Same thing with sensory loss. If they can't see suddenly they have an eye problem or hearing problem, you know that there's a more focal problem or underlying cause. Okay. Also, seizures and gait disturbances, these things do not happen early in the course of AD. They can happen much later, but in the early stage, they don't happen. So this would be another sign telling you, no, this is not AD. Okay, so these are things that you can look, I guess, you can look at the scenario in the question. If he has these things, then you know, and okay, AD, put it at the bottom of the list of your differentials, okay? And think more about, for example, cerebrovascular or ALS, for example, a motor disorder, it can cause like hemiparesis or something, okay? Okay, now this slide just basically explains the various neurotransmitters that are synthesized and used for signal transmission. So these are normally present in our brain, and how acetylcholine is used for the nervous system motor and for motor neurons. We have dopamine, which is mainly for inhibitory control of fine movement. This is important to remember because in Parkinson, once these dopaminergic cells are not there, and that's why they don't have control over the fine movement, and they don't have proper coordination. You need to know GABA. It's mainly where it's in the cord, basal ganglia, cerebellum. It has excitatory signals. And remember that it's in Huntington. They have a problem with GABA. And serotonin, it mainly controls body heat, hunger, behavior, and sleep. And this is more of a physiology slide. I don't know why he put it, but yeah, enjoy. It's important to know that in AD, it's primarily acetylcholine in the cortical neurons that is affected. That's why AD patients are given cholinergics. This is what I wanted to mention in this slide, okay? That's why and I mentioned also earlier, we give them cholinergics because it's mainly acetylcholine that's being hurt or affected by all this neural loss in the brain, okay? Okay, now vascular dementia. So vascular dementia, we said it's a form of small vessel vascular dementia where you have small blood vessels being affected, okay? And then leading to infarction in the brain. And eventually the infarcts in your brain, in the brain of the patient, they accumulate with time until he ends up with dementia, okay? And the risk factors, they're like the risk factors of any vascular disease, or for example, there's sclerosis. The risk factors are hyperlipidemia, diabetes, hypertension, age, okay? So these are important risk factors that you can link with vascular dementia. These risk factors, for example, they're not associated with AD. So this is something you comes with hypertension, diabetes, and hyperlipidemia all together at once. So this kind of makes you think of if they're also presenting with signs of cognition problems, so here, think of vascular dementia rather than AD, okay? It says that my internet is unstable. Wait, am I lagging? ولا كل شيء كويس? Can you guys hear me كويس? Okay. So wait, 1 second. Let me connect to my 4G. Okay, I think you lagged for a second, then it was fine again. Okay, so Hella, it's good. Okay, good. طيب. So we said second most common of dementia, because okay, we said what's the most common cause of dementia? This is على طول. You should answer it directly, guys. AD. Okay, شاطري. Second most common cause. Third most common cause. I mentioned it. Age. No, it's not a cause of Lewy body. Yes, Lewy body. Okay, age is a risk factor. Okay. طيب. So what you need to remember about the vascular dementia is it has a stepwise progression. So how you can remember this is that, let's say AD, it progresses, and we said it progresses gradually. So it goes down like this, okay? While in vascular dementia, no, it goes down like they have a stroke, then they have cognition impairment. Stroke, cognition impairment, okay? You get it? So it's more sudden. It's not gradual. They have like more فجأة بيجي لهم stroke, they get a stroke, and then suddenly they have cognitive dysfunction. Okay, then they're خلاص stable, then they get a stroke, another stroke, and then they have cognitive dysfunction. You get me? So that's what they mean by stepwise progression. Okay, so it's not gradual, it's more stepwise, and their symptoms usually appear after each stroke. Okay, because from its name, it's multi-infarct, so they keep having multiple infarcts that accumulate with time. I want to see if a person has multiple vascular factors that weren't treated, this will lead to loss of certain spots in the brain and will accumulate with time. So the damage gets worse and worse and progressive mental function decline. That's basically what I said. Okay. Now, okay, so these are the risk factors. They can, it can cause small infarcts or large infarcts. Happen more in men than women, because men usually they're more predisposed, if I'm not mistaken, to hyperlipidemia and diabetes. It's associated, as I mentioned, with hypertension. Usually they have history of atrial fibrillation, for example. Why do you think atrial fibrillation is linked to multi-infarct dementia? How can atrial fibrillation be a risk factor or predispose them to it? This is more of a CDS question. It's important because it will keep coming up. Yeah, because it causes thrombus, okay? Atrial fibrillation, they increase your risk of, they can have a thrombus formation in the heart, then the first place it would go is the brain. It would go into the internal carotids, yeah, and then go to the brain, okay? And yeah, carotid bruits, so carotid artery stenosis, that means due to an atherosclerotic plaque in your carotid arteries, then the plaque can like get ruptured, and then it can go to the brain and cause an infarct and a stroke. So these are all signs. Remember again that it's sudden onset and stepwise decline, okay? And they have focal signs, not generalized signs. That's basically it for this. Okay, so then this is normal pressure hydrocephalus. Okay, I don't know why فجأة he decided to talk about hydrocephalus here in the middle. I'm guessing because it can also cause similar symptoms. But we move. So here they basically have hydrocephalus, but the pressure, the CSF pressure is not high. So they present with the characteristic W's, which is weird, wobbly, and wet, okay? So weird meaning they have apathetic faces. So their faces have, it's just, they're emotionless, okay? And there's difficulty completing, they have difficulty completing a sequence, okay? Of sentences. And they have stooped posture, okay? Wobbly meaning they walk in like small steps. So their steps are like stuck together. It's like that's called the magnetic gait, okay? Because they walk in small steps. And wet as in urinary incontinence. They have urinary incontinence. Okay, so they have these three features. And then when you do an MRI, you notice that the ventricles are distended. So this is normal pressure hydrocephalus. And the way you treat that is with shunting. And always keep in mind the major complication of shunting is over shunting, which can cause subdural bleeding. And the way it causes that is basically because you're draining so much CSF, you pull the brain, basically the brain gets pulled from the skull, and then the bridging veins between the skull and the brain, they basically get stretched out because the vein got pulled and separated from the skull. So once they get stretched out, they can easily get ruptured and you have a subdural bleeding, okay? And infection, of course, anytime you insert anything, any invasive procedure, it has a risk of infection. So yeah. Okay. Yeah. Okay. So Amru will just text me if you guys want. We can have a break at 6:15 or till 6:15 actually for. And بالمرة I can go. How is it called? Normal pressure hydrocephalus? I didn't get what does it mean. بصراحة what I think it means is that because you have a lot of production of CSF, you end up with the hydrocephalus, but the pressure isn't high enough to be, I guess, elevated pressure. بصراحة أنا كمان يعني I didn't completely understand it and get it. أصلا it's kind of in a random place بالlecture. حاسة إنه حطه هيك فجأة. But I can make sure to tell you guys, and I'll like find explanation and like send it and let you can Amro, he sends it on the group. Okay. And yeah, so do you guys want a break هلا for Maghrib? And then we can continue at like 6:20, 6:15. Okay. يلا. Hello, is everyone back? Should I start? Okay, so to save us time with the hydrocephalus question, I searched it هلا على طول على AMBOSS, so I can explain it here instead of sending the message later. Okay. So normal pressure hydrocephalus, it's basically, it usually happens when, you know how the CSF is drained in the brain? The CSF drainage begins where first CSF is formed in the ventricles, and then they go through the tunnels and everything and outside to to the subarachnoid space. And then there's granulations. There's arachnoid granulations that are supposed to absorb the CSF, okay? So whenever you have a problem with that, you have something called communicating hydrocephalus, okay? So that's what happens basically in normal pressure hydrocephalus. They have a problem. They have chronic communicating hydrocephalus where they're unable to absorb the CSF. So basically CSF accumulates in the space, in the cerebrospinal fluid, in the entire space of the brain, surrounding the brain. So the ventricles and the between the sulci, they don't get accumulate. And that's why they have high pressure, okay? They have normal pressure because the ventricles compensate, okay? So they become elevated, they become dilated to hold all the extra CSF. And that's why the opening pressure, when you do the CSF tap, it's sometimes slightly elevated, but most of the time it's normal. And that why? Because of the compensation by the ventricles. The ventricles dilate and hold all the fluid so that the opening tap pressure is not elevated. And this happens in chronic communicating hydrocephalus in elderly, mainly in elderly, okay? And I added the information here, okay? In Ohio, it primarily affects elderly individuals, and the reason why he put it here is because it causes dementia, because of all this CSF accumulating. It can cause a triad that I mentioned, and who are urinary incontinence, dementia, and the gait, the magnetic gait, okay? And the causes, it's usually idiopathic, and it can have secondary causes like fibrosis of the subarachnoid villi, okay? And this can happen with inflammatory diseases like meningitis, or if you have even hemorrhage, this can mess up the arachnoid villi or subarachnoidal, either intraventricular or subarachnoidal hemorrhage. Or it can even be idiopathic, okay? But the idea is that you have a lot of CSF accumulating, the ventricles dilate. So on imaging, you have very huge ventricles, but the area around the brain looks normal, okay? It's just the ventricles that are really dilated, and that's called normal pressure hydrocephalus, okay? I think it was Afnan who asked this, صح? Yep, okay, good. And remember, how do you treat it? Shunting. Complication over shunting. It's an invasive procedure, so another complication is infection. Okay. And yeah, that's pretty much it. I said the main important things. Now, frontotemporal lobar degeneration. So this is the one that I told you that's focal. It affects only certain areas, and from its name, you can tell which areas get affected. So it's again progressive deterioration. They have problems with language and personality. But where is the degeneration? Which area is affected? The temporal and frontal lobes. Okay, so that's a difference between it and Alzheimer's, that the area affected is the frontotemporal lobe. Now, sometimes the patients, they're not always copy-paste. They don't always present clinical features the exact same way. Okay, so some may have more frontal lobe degeneration. So if they have more frontal lobe degeneration, they'll present with what? Behavioral changes, okay? But if they have more temporal lobe degeneration, then they'll have what? Mainly language problems. That's their main complaint. And this all has to do with the function of each of those areas. So you know that our frontal lobe, it's mainly, it's the one that mainly is responsible for personality, behavior, and all that. Temporal lobe is more connected to language. You have the parietal and occipital. Each area has its own function. So frontal lobe, if it's the main part affected, then they'll have behavioral changes. Just remember that. Temporal, language problems. Okay. So you look at their main complaint, and you can tell by that. Okay, so these symptoms precede memory disturbances, which can assist in their separation from AD on clinical grounds. Okay, that means they don't have memory disturbances as their initial complaint. They usually come with language problems or behavioral changes, and then they end up with eventually dementia, basically memory disturbances. Okay, so that's in AD. They first come with memory disturbances. They're forgetful. They can't remember what time it is, for example, what did they eat yesterday, something like that. And yeah, and it's also related to, again, accumulation of certain proteins, and it can even be inherited sometimes. Okay. Here, I added something, it's important. Sometimes it can be mistaken for Pick's disease, which is a subset of frontotemporal dementia, and it's characterized by the presence of Pick bodies, okay? That's in Pick disease, okay? And in Pick disease, these bodies are spherical tau proteins, not tangles. In AD, they're tangles. In Pick's disease, they're spherical, okay? And what's Pick's disease? It's basically a subset of frontotemporal dementia, okay? Now, prion. Okay, so prion disease. You're all معاي صح؟ بس now, because prion disease is شوية زنخ بصراحة. But yeah, okay. So a name for prion disease is basically spongiform encephalopathy. Okay, and what that means, spongiform, sponge, that means it looks like a sponge. Encephalopathy, brain, disease in the brain. Okay. So basically in prion diseases, their brain looks like a sponge, and it's basically because of multiple cysts being formed due to this degeneration process that happens in prion disease. And do you guys know what the underlying protein responsible for prion disease is? I mean, from its name, you can know, but yeah. PRPC, okay, that's the gene mutation, yeah. What's the protein called? Right, yeah, good job. So prion proteins, they accumulate. So what's a special feature of prion proteins? Yani, I'm jumping ahead here, but I want to see if you guys know. What's so special about prion proteins? Do you guys know anything about prion proteins? How they can, how do they develop type? They can infect other proteins, yeah. But the word here, the key word here is not to say infect, because that's the problem. You know, when a patient presents with such a case, you would think it's an infection, but it's not, because they don't find any inflammatory reaction. There's no immune response, so it's actually not an infection, but it's this protein that it's contaminated. Let's say that once a person becomes contaminated with this protein starts accumulating, and it starts making the normal prion proteins become like it, abnormal. Okay, and what's the abnormal form of the prion protein? It's basically abnormal folding. Exactly, I can see it. And yeah, it's not due to a virus and not due to bacteria. It's just something that's هيك فجأة بيصير. It's sometimes sporadic, and sometimes it's familial due to a mutation that runs in the family. Or sometimes you can get it by eating meat that's contaminated with it. I didn't say meat infected. I said contaminated, because it's not a bacteria or a virus, okay? So like cows, a long time ago, when they used to eat cows, or they used to eat sheep that had this prion protein, they would end up with prion disease, because they'd get that protein in their system. Then this protein would accumulate, because you don't have any way of degrading this protein in your body. So because you can't degrade it, it accumulates, and it makes, on top of that, it makes the other prion proteins abnormal like it. And additionally, which makes it seem like an infection, is that you can transmit it to other people. So if someone has is contaminated with prion protein and he gives a blood transfusion, the person receiving the blood transfusion can get the prion disease. That's why it can be sometimes thought of as an infection, but it's not really an infection. Okay. So that's what you need to remember about prion protein. Okay. Not an inflammatory response, no immune response, and because of and as I said, whenever you have accumulation of any protein, the cells will degenerate. Okay, it's cytotoxic. It will cause cell degeneration, and then they form in prion disease. They form cysts all over the brain where the degeneration happens. That's why it looks like a sponge. I mentioned here what I explained basically. Here are some characteristic changes that are written here already. Spongiform. You'll find spongiform changes, which is basically the brain looks like a sponge. Reactive gliosis, it's a normal process that happens in response to injury in your brain. Neuronal loss as well, because they're degenerating, and amyloid plaques begin to form as well. And the most common cause of prion disease, because as you can see, it's diseases, so it has many different causes, but the most common cause is the Creutzfeldt-Jakob disease, okay? And the Creutzfeldt-Jakob disease has also multiple types, like the variant, the iatrogenic, the familial, the sporadic. We'll see them, yani. Then there's Kuro. Do you guys know what Kuro is? It's the special one. It's caused by what? Yes, from cannibalism, because it's famous because there was a tribe a long time ago that would eat human flesh. So they got the disease from so that's how the disease was transmitted among them and caused Kuro. Okay. Yeah, that's basically this. And you just know that whenever there's prions in cows, they call it bovine spongiform encephalopathy or mad cow disease. Whenever it's in sheep, they call it scrapie. Okay, it's just terminology basically. Whenever a human, for example, has prion disease, they don't say it's bovine spongiform encephalopathy. No, they call it Creutzfeldt-Jakob or variant, depending on what's the cause. Okay. And then this is the process that we just explained. And we have this PRPC protein that gets abnormally, the conformation changes. Remember, the problem is not in the DNA structure, okay? The pathophysiology is usually not DNA structure, it's misfolding, okay? And then the misfolding accumulates, it makes other normal ones just like that, and then until eventually they have all prion proteins. Okay. Now Creutzfeldt-Jakob disease. So usually it's 1 per million population. Median age at death is 68 years. So it happens more in elderly. Remember, the presentation is dementia, because it's one of the dementias. It picks prion disease under the dementia disorders. So it causes dementia, visual problems, and cerebellar dysfunction. Okay, so here it can affect the cerebellum. It depends again on what area, what neurons have the protein, okay? Depending on that, they will have the symptoms. So it begins with dementia, visual problems, and cerebral dysfunction, but then it can end up with myoclonus, tremors, and rigidity. Okay, these are subsequent symptoms, so they come later. And here is again what I pointed out earlier when I said some disorders they're slow progressing and some are rapid. So Creutzfeldt-Jakob disease is one of the rapidly progressive diseases. That means once they have it, khalas, they have mental illness within 4 months. So it rapidly progresses, unlike AD, which can stay with the person more than 10 years. Okay, so remember this keyword that Creutzfeldt-Jakob is rapidly progressive, AD is slowly progressive. And yeah, so here كتبوا كمان إنه more than 50% die within 6 months. Others can die within 12 months of onset. And then for diagnosis, it's mainly clinical course. They look at the clinical course because again, this is just like AD. You cannot confirm the diagnosis until, what's it called? Until you do autopsy. Okay, so until the patient is like, khalas, he died. After he died and you do autopsy of his brain, that's when you can confirm the diagnosis. Other than that, when he comes to your clinic, what do you do instead? You do EC, you take history and physical, of course, but you can also do EEG, CSF testing. So check his neuronal brain patterns and do CSF test for the protein, which is 1433. It can tell you how much of neuronal destruction there is. Okay, so the higher it is, the more neuronal destruction there is. And you can also do genetic studies if it's the familial form. You might have the genetic mutation. Okay, but yeah, that's pretty much all you can do. And like I said, then early symptoms are mainly motor symptoms like ataxia, neurologic symptoms, and behavioral state changes. Late symptoms are myoclonus, muscle weakness, and dementia. This is according to, I think, Ambos or Osmosis, one of them. I think it's Osmosis, yeah, because I noticed here he wrote dementia first. Just go with the slides, okay? Remember the signs. Usually he won't give you just these signs alone in the scenario. He has to give you some indication that he maybe ate a cow that was contaminated, or he had a blood transfusion from some possible contaminated source. He'll mention that something about the prine protein. He'll give you some hint, okay? He won't just give you these symptoms, okay? Then the types, okay. So these are the types that I briefly mentioned, Benshwai. You have sporadic, which is basically random. It happens by suddenly in someone who's normal, his protein starts becoming malformed, and then he develops a prime protein. The variant one is due to bovine to human transmission, when you have basically bad cow disease, when you eat the contaminated cows. And this was more popular in the 1981 to 1996 in UK. The familial form, this happens when you have, because it says familial, so it's due to inheritance, okay? So when you have the PRPC mutation. And then iatrogenic is when you get it from corneal transplants, from basically medical procedures like corneal transplants and cadaveric human pituitary hormones. So remember these two examples. Like you can get, for example, a patient with history of corneal transplant, he presents to you with some dementia and everything, and then he can give you this iatrogenic CJD as an option. But honestly, from what I remember, they rarely ask about CJD, unless it's like a very obvious question. So yeah. And yeah, and just remember, in all of these types of CJD, they cause spongiform degeneration of the cerebral cortex and cerebellum. So they have signs of ataxia in the early stage. AD, that doesn't happen in the early stage. Okay, so if you look at the MRI of this patient, what will you see? You'll see hyperintensity in the regions of the basal ganglia and caudate bilaterally. So those are the areas that are usually affected in the cerebrum. The MRI findings, they're associated with rapidly progressive dementia, because I said it's once they get it, it progresses rapidly. So that's a key word, rapidly progressive. Myoclonus, EEG changes that show slow waves with periodic spikes. And these three things, they suggest Creutzfeldt-Jakob disease. So if they wanted to get your question about Creutzfeldt-Jakob disease, you look for these three things in the scenario. They'll mention a patient, he came with 3 weeks of forgetfulness. On physical examination, for example, he can tell you, he had myoclonus. He won't say myoclonus specifically, let's say the actual examination. And then he'll say EEG showed some slow spikes, for example. If he wants to really help you, he might mention the EEG changes. And then he can ask you, what's the diagnosis or what's underlying pathophysiology. And yeah, I don't think they would ask you about management, صراحة. But that's how you can link them, okay? And okay, that's for prime. This is the hyperintensity lesions, as mentioned. You can see them in the caudate and we said caudate and basal ganglia. Yeah, so here in the basal ganglia. And the caudate would be somewhere around here. Okay. Then this is just a random one slide about how HIV can cause encephalitis. So you need to keep it in mind. HIV encephalitis can lead to dementia. This is obviously in patients with HIV infection. They can have, if HIV spreads to their brain, it can cause inflammation, which can lead to dementia. And the way you can accept this, unlike the other types of dementia, this can be diagnosed because you know from the symptoms, and he has HIV usually. And he would have multinucleated giant cells or perivascular accumulations of macrophages. Yeah, the Zank smear basically. Yeah, I think that's not really high yield. Okay, now Parkinson's disease. This one, they'll definitely ask you about it. 3 things they like in this entire presentation is Alzheimer's, Parkinson, and Huntington. Okay, these are the 3 ones that I'm pretty sure they would mention at least one question about each. Okay, so Parkinson's disease, it's idiopathic, males more than females, we know this. Risk factors, age, atherosclerosis, environmental factors, drugs, head trauma, so it kind of overlaps with the risk factors of AD, except AD had more of Down syndrome as well. age is more of a risk factor there too. Here, it can be sporadic or familial. Whenever I say familial, again, that means it's inherited. So they can get it due to a mutation in the alpha synuclein. So one of the questions can ask you, and they can give you a presentation of Parkinson and then ask you what's the underlying mutation that can cause it. And he can tell you, and one of the options can be mutation of the alpha synuclein, okay? Now, how do they present? As I mentioned, it's a movement disorder. So they would present with tremor, rigidity, bradykinesia, arm swing, lost festinating gait, which is basically here shuffling gait as well. Okay, you need to remember these words. أهم إشي, rigidity, bradykinesia, and tremor. What's the type of tremor that they have in Parkinson's? Do you guys remember? Let's wake you up شوية. What's the type? Pill rolling tremor, exactly, and it's resting. That's very important to remember because most of the other disorders, they cause intention tremor, which it goes away with rest and gets worse with movement. So when they start to move, that's when their hand shakes. But in Parkinson's, no, it's when they rest their hand, they notice that their fingers keep doing this, pill rolling. They're rolling a pen. Rigidity, you need to remember, for example, cogwheel rigidity. They mention this a lot. They're doing the physical examination on a patient, and the patient's on passive movement of the patient's hand, they find it's stiff. It's like a cogwheel. So this is cogwheel rigidity. Okay, when the doctor is trying to move the patient's hand, he finds it rigid and hard to move. Okay, so this is called cogwheel rigidity. Cerebellar diseases, if I'm not mistaken, they have intention tremors, the ones that go away with resting. Yeah, and we'll discuss them also there near the end. Bradykinesia, yeah, we said they're slow because of the impaired movement and everything. And what's the underlying cause? We mentioned this before. It's a problem in the Substantia Nigra. So dopaminergic neuron cells degenerate, and then they have loss of dopamine. Okay. And here they usually end with immobility. So they usually end with reach a stage where they can't move at all. Okay. In Alzheimer's disease, do you guys remember what causes death in Alzheimer's disease? I said, it usually progresses with them over a couple of years, more than 10 years, but then they eventually die due to, yes, pneumonia and infection. Good job. Here, they usually end up being immobile. They could even die also from pneumonia infection, but he didn't mention it specifically. But that's just to see if you guys remember. Okay, so yeah, usually 10 to 15% develop dementia with advancing age. So this is another distinguishing feature. They develop dementia when later on in the course. Their main symptom, kullu, movement. Once you see movement symptoms, you think of Parkinson, Huntington. Those are the first two you should think of, okay? If you see dementia first, then you think of dementia, AD first, okay? So yeah, these are some, I also mentioned here, you can have some environmental factors that cause Parkinson, like pesticide and insecticide. So he can even give you in his history, he's a farmer and he uses pesticides a lot for his farm. Under microscope, we said the protein seen here are the Lewy bodies, okay? And some interesting fact is that smoking is actually a protective factor in Parkinson's disease. Of course, that doesn't mean you should suggest the patient, they smoke. That's the no, yeah. It's an interesting fact. Diagnosis, again, like AD, no imaging, no blood test, it's clinical, okay? So it's all based on the clinical presentation. And that's why you guys need to memorize the clinical presentation by heart. And you can do this by solving lots of questions on the disease, and you'll get the hang of identifying it, basically. So here the prognosis, usually in the first 5 years, the patient takes his medication and it's effective, but then later on, the medication becomes less effective. Why? Because as we said, this disease is progressive, like most neurologic disorders. So eventually even the medication starts to not help, okay? So that's one thing you need to keep in mind. Yeah. And then this is the progression of symptoms. Oh, okay, so you have the main three that they present with: akinesia, rigidity, and tremor. We said resting tremor. And then they could end up with what? During the end of their course, swallowing difficulty, incontinence, drooling, as it spreads more to other areas get affected. Immobility, exactly. أهم إشي, something here that I want to mention, yeah, it does not cause muscle weakness, okay? Why doesn't it cause muscle weakness? Trying to hide the. Why does Parkinson not cause muscle weakness? Can any of you guess? It actually doesn't even affect the upper motor neuron. Oh, maybe it can affect the sorry. It can sometimes affect it, but it's mainly it's in the basal ganglia, substantia nigra specifically. It's affecting dopaminergic cells. It's not affecting motor neurons. Okay. So yeah, actually it doesn't even affect the upper motor neurons, my bad. So it helps, that's why it helps you differentiate it from motor cortex and cortical spinal pathway diseases. Because for example, ALS, it affects both upper motor and lower motor neurons. So they'll have symptoms of spasticity, they'll have muscle weakness, okay? But in Parkinson's, they don't have these symptoms because those cells aren't affected. It's only the substantia nigra cells. What else? Resting tremor, and the resting tremor helps you differentiate it from the cerebellar diseases, which could cause the action tremor or intention tremor, okay? Which we mentioned من شوي. That's it for this part. This is the picture he added, يعني, just so you can see how they have like the aphasic face, the shuffling gait, the pill rolling tremor, okay? These are signs that you can do with physical examination. You have the glabellar reflex, where you tap. If a normal patient, when you tap them here, they'll blink for the first time you do it, but then the other times, they'll get used to it. Okay. In a patient with Parkinson's, no matter how much you do it, you keep doing it, they'll blink every time. Okay. So that's called the glabellar reflex. You also have the quick scratch on the palm of the hand will induce contraction hina. I don't know what's the underlying pathophysiology or like the link between it, but they're just positive signs of Parkinson. Okay. And then this is on autopsy. If you want to confirm once the patient is dead and you want to see his brainstem or basal ganglia, you'll notice that the substantia nigra got depigmentated, and this confirms that he did have Parkinson's because all the dopaminergic cells that were pigmented, they died. So now he has depigmentation. This is a common, by the way, picture they use for OSCE or maybe SAQ or anything. They usually bring a picture like this and ask, okay, what's the underlying cause, or what drug, since you guys took medication for this, could ask you what drug they can give. And yeah. Remember, the brain command, it can be normal or mildly atrophic. Okay, so the general brain might not look like it's affected. It's just the substantia nigra, unlike AD, where the brain is affected, or frontotemporal dementia, the brain gets affected, like there's atrophy. Okay, here there's not that much. It's mainly, again, the substantia nigra. Okay, now Parkinsonism. So do you guys know what Parkinsonism is? Try without. Do you know what Parkinsonism is? From its name. Yeah, so it's a Parkinsonism. Yeah, so it's basically when the patient have symptoms of Parkinson, but Parkinson is not the cause, exactly. And it's usually due to medication. It can be due to many different things, but medication is one of the top causes. So they have, it's basically symptoms of Parkinson that occur in any other disease, and they're usually or they can occur as side effects of medication, like what? Haloperidol and metoclopramide, okay? The thing with haloperidol, metoclopramide, they both act against dopamine, okay? One of them, I think haloperidol is a dopamine receptor antagonist, and the other one inhibits pro-dopamine or something like this. بس المهم إنه both of them decrease dopamine's activity, and that's why they can cause Parkinsonism symptoms, okay? And so they have the whole clinical syndrome, اللي هو rigidity, pill rolling, diminished facial expression, stooped posture. They have bradykinesia and fascinating gait, okay? They can have rigidity versus spasticity depending on the area affected. One thing you need to remember, it's more common than Parkinson's disease. Okay, so having Parkinsonism is actually more common than having Parkinson's disease. And it can be due to a neurodegenerative disease, a different one, okay? Or it can be due to the side effects of the drugs. What else? Striatal pathway. And mainly the pathways affected are the striatal pathway and the striatum. They're extrapyramidal pathway in the control of movement, and they facilitate automatic movement such as blocking, and becomes more stiff and less flaccid. They cause basically rigidity because they affect the extrapyramidal pathway. Okay. And it's mainly, as you mentioned, drug induced. That's all you need to know. بصراحة هنا. Okay, so هو هنا حط إنه the other diseases, the underlying diseases that can cause Parkinsonism, and حط some specific factors. I added this table from Ambos. Okay, you don't need, I'm pretty sure you don't need to know all of this, but إنه يعني just so you have a clear idea and distinction between them. That you have Parkinson's disease, vascular Parkinsonism, you have muscle system atrophy, the progressive supranuclear palsy, and corticobasal degeneration. All of them what cause Parkinsonism or Parkinson syndrome, the symptoms of Parkinson. Okay, but each of them have are different in their age of onset. They're the first symptoms that appear, the symmetric, if it's symmetric or not. Okay, I don't think you need to know all these details. Just know the things that he wrote here. I don't think you need to know more than that. You already know Parkinson's disease. That's what we talked about, okay? Multiple system atrophy. It's due to Parkinsonism as a prominent symptom, as well as other symptoms like cerebral. They would have cerebellar ataxia and autonomic dysfunction, revealing alpha-synuclein in oligodendrocytes, okay? So it affects mainly oligodendrocytes, and they would have also cerebellar ataxia and autonomic dysfunction, okay? Progressive supranuclear and corticobasal degeneration, they usually exhibit cognitive impairment, and they show tau containing inclusions. Okay, so for example, Parkinson's disease does not show tau containing inclusions, and here they are more associated with cognitive impairment. Post-encephalitic, this usually happens in the wake of due to influenza. It's not common now. You can also have Parkinsonian syndrome with if they have manganese poisoning, carbon monoxide poisoning, hypoxemic, ischemic encephalopathy, or traumatic brain injury. These are other causes. So they all the difference is that they both are very severe and they affect the gait very early. That's the difference between these diseases and actual idiopathic Parkinson's disease. And in Parkinson's disease, they usually come in a chair. If they come in a chair, then it's not idiopathic Parkinson's. It's usually one of the diseases above, okay? So if they come with a Parkinsonian-like disease, that means they come with Parkinsonism, okay? And they come in a wheelchair, you know it's not Parkinson's disease. Why? Because the Parkinson's disease, they don't end up in a wheelchair until what? The end of its course. So they usually come to you earlier on. But if they come with Parkinsonian symptoms, okay, and they're in a wheelchair because of the whole problem, because of motor deficits and all that, then you know it's not Parkinson's disease. It's another disease that's causing Parkinsonism, okay, or Parkinsonism, okay? I think that's pretty much it, what you need to know about that. For management, again, it's mainly symptomatic. There's no cure for Parkinson's disease. So they can give dopamine in the form of levodopa. They can add, what's it called, the other drug called what's it called? You guys know the name. Carbidopa. Carbidopa. Yes. Okay. What does carbidopa do? Why would they add it to a levodopa? This is to test your pharma. Yes, dopa decarbonate. It basically inhibits the breakdown of dopamine. So that, because when you give anyone medication, okay, it first usually passes, it can get metabolized in the liver by this enzyme, okay? It can get metabolized. So you don't want the levodopa to become metabolized. You want it to go to the brain. You want it to reach the brain. So in order to do that, you give carbidopa to inhibit the breakdown of this medication. Exactly. And to increase the bioavailability of levodopa or dopamine in the brain. Okay, so that's basically the main medical treatment. There are other medical options, but they're not here, and it's more in your pharma lecture. Of course, they need to focus on their exercise and ambulation, all that. Surgery, Hina, I'm going to focus more on the surgery because he mentions it. Now, surgery, the one that's more common nowadays is the deep brain stimulation. But before, they used to do pallidotomy or thalamotomy, where they basically go in and destroy some parts of the thalamus and the, let me find this name right. I wrote it here. Yeah, pallidotomy. So I think some parts of the basal ganglia and the thalamus, okay? And they would do this because those areas become hyperactive in Parkinson's disease, and they cause this, the tremors and the rigidity, okay? So they do that to basically improve his symptoms. So again, it's still symptomatic management. It's not a cure, but they do it when the patient has tried medical therapy, he's tried all sorts of therapy, his symptoms are still persistent and they're tiring him. So he just wants to get rid of it. So they used to do a thalamotomy or palidotomy, okay, to relieve him of these symptoms. But now they do a better procedure, which is deep brain stimulation. It's like high frequency, it's not invasive, it's from outside. They send high frequency waves to the brain that to these overactive areas to stop them basically from HADA. And it has the same outcome. It also relieves their symptoms of tremors and everything. And there's no loss of tissue, which is why it's better, okay? And that's what you need to know for the surgery wise, yeah, that they do. And the drug therapy, yeah, they mainly their goal in Parkinson's disease is to increase dopamine and decrease acetylcholine. While in Alzheimer's disease, they want to increase acetylcholine. That's why they gave cholinergic agonists there for cholinergic drugs. Okay. Okay, now Huntington disease. So is everything clear with Parkinson's? What do you guys know about Huntington? What do you know about Huntington that's special? Is it sporadic? Is it hereditary? Is it due to, it's a yes, it's caused, so it's hyperkinetic disease, yes, hereditary, caused by repetitive CAG. Starts between 20 and 50. And what's usually what type of counseling do you usually need to tell a patient? So let's say he's like a newlywed and he realizes he has Huntington disease. What do you need to tell him for his future? He just got married and he's diagnosed with Huntington disease. What do you need to counsel him on? Contraception? No, they can have kids, I mean, بس إنه يعني what do you need to tell him to anticipate so that he anticipates? He needs to basically anticipate that his children, there's a high chance of them having Huntington, and it's going to be more severe in his children, and they'll have an earlier onset. Why is that? Because the tandem repeats that he has, once he inherits that mutated gene to his child, they will be expanded even more. So the child will have more repeats of the mutated gene than his dad. So that's why the child ends up with a more severe and more early onset disease. How can we prevent this? Wallahi, I think screening, is it autosomal dominant? I think it's autosomal dominant. So يعني, even then they could do مثلا IVF. That's a common thing for many diseases. يعني, whenever they want to prevent having a kid with such diseases, they usually do IVF. And it's a lot actually. One of the biggest facilities, by the way, for IVF in Saudi is in KFSH. So we've seen patients who do that because there's a lot of genetic diseases here. So I'm guessing they would refer to IVF because in vitro fertilization, in case you guys don't know what IVF is. But yeah, that's probably their only thing, because Huntington, once you have it, you can't really stop it. There's no cure for it. Okay, so it's an inherited autosomal dominant disease. Again, progressive, movement disorder. They can also have behavior changes and dementia. One thing you need to remember is that Huntington disease, usually the patients can also, it's commonly associated with the depression and suicide. Patients usually can end up with suicide, okay? I don't know exactly why, but these are associated with Huntington. They usually have these things, in depression, or sometimes they even die of suicide. That's their main cause of death. It's because they commit suicide because of the depression. Histologically, they have degeneration of the striatal neurons, okay, which we said are related to GABA. Related to GABAergic neurons, okay, and they don't have any sporadic form. This is important to remember, like Parkinson's and the rest, Huntington, Creutzfeldt-Jakob, most diseases, they have a sporadic form. But here they're saying Huntington, there's no way you can have it unless you inherited it. That means he has to have a positive family history, okay? No patient will come to you هيك فجأة with Huntington. He'll always hint in the scenario that he has a family history, okay? And the age of onset usually is 40 to 50s. But again, like I said, it can happen earlier if their father, for example, or mother or whatever, they got the disorder. Okay. And as mentioned, it's a movement disorder. They'll usually describe it as chorea. If the doctor is generous, he'll say he has chorea. But if not, he'll say he has jerky movements, hyperkinetic. He has irregular movements of the hand and neck, for example. He'll say that. He won't say chorea because he doesn't want to make it easy. It can affect all parts of the body. So you can see this hyperkinetic movement in all parts of the body. مشات بس hand and neck. They can have seizures, rigidity, depression, and cognitive impairment. Again, it can cause dementia. What they develop later on, they can develop Parkinsonism with bradykinesia and rigidity. So that's important, but that's later on. So yeah, it's relentlessly progressive. That means it gets a lot worse with time, and the average course is 15 to 20 years to death. Okay, so they, like I said, there's no cure, so they eventually do end up dying within 15 to 20 years. And usually it's due to incurrent infection or suicide. Yeah. So as I said, the pathophysiology, depletion of GABA producing neurons, which normally inhibit the motor activity. So they have what? Excess motor activity, like chorea. The mutation is where? It's on chromosome 4. Okay, so it's HET chromosome form. The normal number of repeats you have is usually 10 to 35. When do you get the mutation? When you have 36 to 120 repeats. Okay. And as I said, as you pass on the gene, the expansion of the mutated gene gets more and more and more. Okay. And the clinical features, we said, you can see chorea and hyperkinetic movements. He'll usually say irregular, non-repetitive arrhythmic movements. Dystonia, this is important. Sometimes in the scenario, he'll say, no, he has delayed return to neutral with plantar reflex because of dystonia. So he won't say he has dystonia. No, I'll say what's delayed. He has delayed return to neutral with plantar reflex. Okay. And yeah, he can also display depression, aggression, dementia, and usually it occurs after 10 to 20 years, they die because of it or because of infections. But we're almost done. Okay, so Huntington disease pathogenesis, this is what I explained. Again, we have an abnormal accumulation of repeats, the polyglutamine in Huntington yielding fragments forming internuclear aggregates. So you do have, again, a protein or something aggregating, but here it's internuclear, okay? Never mind, I hate this stupid shadow thing. Okay, so again, you have aggregations where? In the nucleus, okay? Maternal transmission may be associated with earlier onset in the next generation. Again, usually when you get it from your father, it has an earlier onset in the next generation. And that's why you need to do genetic counseling with the patient because they need to know. Do they have any movement problems or only chorea? They have dystonia, okay? They have, what else? Come on. They can have jerky hyperkinetic movements, but it's mainly chorea. That's the dance-like feature that characterizes it. So usually if they do, how will they ask about it? How will they present? They have to mention something about chorea, okay? Chorea, because that's their hallmark feature. Okay, and then this is how it looks, because we said it affects striatum. So you can see here how it's atrophied compared to this side. Especially the caudate, okay. There's, again, whenever you have atrophy, there's always increase in the ventricle size. Okay, now ALS. ALS, we said it's a motor disorder, affects the upper motor and lower motor neurons. It's the most common type of motor neuron disorder. What do you need to know? It also has, it can be caused by mutation, which is a hexanucleotide repeat expansion. In which gene? It's in a gene on chromosome 9, P21. Okay, so that usually means that there's a translocation. When they put 9 and then P21, that means it's a translocation. You don't need to worry about that right now. But what you need to know is that ALS can be caused by many different genes, mutations. What you need to care about more is the different types of presentations. Okay, so they can present with upper motor neuron signs or lower motor neuron signs. They can present with weakness, fasciculations, dementia. They can present with dysphagia, difficulty swallowing. So it depends on, like, it can vary depending on the patient. Some present with they start first with muscle weakness. Others first present with dysphagia. And usually what leads to death is respiratory compromise. Usually their diaphragm gets affected, so they're not unable to breathe, and then they die because of respiratory distress. Okay. So here I wrote about the genes involved. Here SOD1, TARD, BP, these genes. The most common one is this gene. I don't know if you guys need to know this, but I just wrote them here. Disease progression, usually the the classic form, let's say the classic form of ALS, it usually starts in one arm and one leg. They have spasticity or weakness, and then it progresses to the contralateral side. Okay, and then eventually after months or years, it affects the respiratory system, and that's usually when it's end stage and they die because of it. Clinical features, they have early signs, which are variable again, depending on what's more affected in the patient. They would have limb weakness, bulbar symptoms. So the bulbar muscles, when they're affected, they cause dysphagia, dysarthria, tongue atrophy, and weight loss because they can't eat and they have difficulty eating and swallowing. So they can have weight loss. They can have muscle stiffness, cramps, split hand sign. Late complications are cognitive impairment, autonomic symptoms like urinary incontinence, fecal incontinence. These are autonomic symptoms. Life-threatening symptoms are respiratory failure and dysphagia due to bulbar weakness. Okay, these are the ones that you know, no, khalas, he's gonna die soon. Okay, so like I said, I know the ALS, symptoms of ALS are variable. Not all patients will present the exact same. So they classified, this is how they made a classification for all the known ways ALS can present, okay? I added it more clearly here. Okay, so you can have the classic ALS, which shows what deterioration of upper and lower motor neurons, okay? This is the more common ALS. You can have the progressive muscular atrophy, which prioritizes what it's more lower motor neurons that are affected. So in progressive muscular atrophy, the lower motor neurons are affected more than the upper. So they usually present with what? Muscle weakness and paralysis, okay? They don't have spasticity and rigidity. In primary lateral sclerosis, it's the opposite. The upper motor neurons deteriorate and the lower motor neurons are not affected within 2 years, okay? And this is the rarest form. Progressive bulbar palsy, they usually present, they're the patients that I told you, they come first with difficulty in speaking, chewing, swallowing. That's the first few signs they come with, okay? And then there's familial, the one that's due to the genes that we mentioned, okay? So this one, and usually you see in multiple people in his family have it. Okay, those are just classes. Okay, now cerebellar ataxias. Okay, so cerebellar ataxias, what did you guys say about it? The main feature, they would have what type of tremor? Intention, yes. Okay, and what else do you think? What does ataxia mean? Unstable gait. So they'd have this, so their gait would be disturbed. Okay, that would be that's one of the main features. So the cerebellar ataxias in general, when I say cerebellar ataxias, it's not just one disease. It can be caused by so many different things. A lot of times they got us question about I remember one question, the acute alcoholic intoxication, because it's very common. It can cause, if I'm not mistaken, vermis cerebellar ataxia because it affects the vermis. But in Muhim, it was due to, you should associate alcohol intoxication with cerebellar ataxias, okay? Thiamine disease, so اللي هو Wernicke-Korsakoff disease, it can cause cerebellar ataxia. Posterior artery stroke, cerebellar tumors, drugs like phenytoin, they can all cause cerebellar ataxias. So it doesn't have to be a neurodegenerative disorder. And usually how do they present? Gait ataxia, truncal ataxia, limb ataxia, intention tremor, diadochokinesia هذا, dysarthria and oculomotor, okay? They're all signs of cerebellar ataxia. For spinocerebellar ataxia, this is more specific to a group of hereditary ataxias that are inherited through genes, okay? And here you have degenerative changes in parts of the brain that are related to movement, which is cerebellum, and sometimes in the spinal cord as well, okay? And what you need to know about this is that it's just autosomal dominant and you have so many different entities and many different, due to mutations. It's classified according to the mutation that's mutated gene responsible for it, but you don't need to know. I think what you just need to know about it is that it's a type of ataxia. It can cause ataxia and it's autosomal dominant, okay? Well, the signs and symptoms can vary depending on what type of mutation you have. Now, Friedreich ataxia, that's the one that we're going to talk about. هو عمل entire thing about it. So, do you guys know what Friedreich ataxia is? You know, what mutation causes it? Or where does the mutation start? يعني where's the starting point? May I ask you to do a recap on the diseases, especially the new ones? This is Afnan. Okay, Afnan, yeah, I'll get to it. Let me finish the slide, then we can recap whatever you want, okay? Frataxin protein, okay, yeah. But you know, what's the organelle affected in the cell? Mitochondria, okay, so it starts with a protein that's supposed to be in the mitochondria. It's responsible for regulating the cellular levels of iron, okay, which is the frataxin, okay? Frataxin protein, just like Ahmed said. So once it gets mutated, and the mutation is what? It's a GAA trinucleotide repeat expansion. So again, it's an expansion mutation where the repeats became more above normal. And as a result, the protein is abnormal. So you can't regulate the iron levels. The protein reaches the cell develops oxidative damage because of the accumulation. And then this leads to Friedreich ataxia, because this specifically happens in cells in the cerebellum, okay? So that's basically what's written here. The repeat expansion results in decreased protein levels through transcriptional silencing. So if you don't have frataxin, you'll have mitochondrial dysfunction and then oxidative damage, and then the cell dies, okay? So because of this, and we said it mainly affects the cerebellum. So the patients present with what? Gait ataxia. They'll have hand clumsiness and dysarthria. They can't coordinate their movements, okay? And because it's genetic, they present very early in the first decade. So he comes to you as a 10-year-old or a 8-year-old, for example. Affects the dorsal column and spinocerebellar tracts. I think, yeah, because he mentions it here. Degeneration of their axons and peripheral nerves, dorsal roots and posterior columns. Loss of neurons in the dorsal nuclei of Clark, and degeneration of the dorsal spinocerebellar tracts. Okay, that's why it also has, it causes dysarthria as well. Okay, so it overlaps between dysarthria and as well as ataxia. Okay. أهم issue what you need to remember, yeah, I know this protein, it's present in three main organs, okay? The pancreas, the heart, and neurons, okay? So it's present in cardiomyocytes, neurons, and pancreatic cells, specifically pancreatic beta cells. That's why they come to you with signs of not only ataxia, they can come to you with signs of heart failure. Okay, this is a more of end stage, but they would have hypertrophic cardiomyopathy. They could have signs of insulin resistance. So in the question, they could mention that his glucose levels are very high. Okay, if he has those three things, you would think more of Friedreich ataxia. Okay. And that's because this protein, the frataxin protein, is present in those cells as well, not only neurons. How do they present? Again, so gait, abnormal gait, that means difficulty walking, wide-based gait. They would have also muscle weakness, because as mentioned, it affects some of the tracts in the spinal cord as well, and loss of proprioception because of posterior columns and the dorsospinal cerebellar tracts. It usually starts with what? His legs, then moves up to the torso, and then he ends up with dysphagia. In a late stage, he can end up with, because of the severity of the disease, and we said it's progressive, he'll end up being in a wheelchair. He can have loss of vision and hearing, and even present with heart failure. These are more late stage presentations, okay? Diagnosis, since it's a genetic disease, diagnosed by genetic testing. They just do genetic testing and they find the mutation. They can do MRI for the brain and spinal cord to see the lesions. They can do ECG command for the heart to see how damaged the heart is and how the wall thickness, to see how severe is the cardiomyopathy. And again, treatment, there's no cure. There's nothing for slowing down the disease or stopping it. It's all symptomatic. So yeah, a lot of these diseases, they're all the same. Symptomatic treatment, basically. And this is just the same thing, childhood ataxia. Now I have questions. Okay, but before I do the questions, Afnan, okay, what diseases you wanted me to go over? I know. You said recap on the diseases, especially the new ones. Do you mean these, let's see, H. Huntington, you mean the ALS? Oh, ish. هو generally what you guys need to know whenever you see إنه headings with brief words, then that's all you need to know. Okay, what you need to know about the disease is what the statement beneath them. Okay, the ones that have actually long slides, those are the ones that you need to focus on. Okay, so she said prions, frontotemporal, or vascular. Okay, so vascular dementia على طول. What risk factors do you think of, guys? In the scenario, he has to mention what? He has to mention atherosclerosis, dyslipidemia, hypertension. He has to mention that he's had stroke before, for example, or you should know that vascular dementia, link it على طول إنه they have multiple infarcts. They have stepwise progression, okay? So they're all progressive, but vascular dementia is stepwise, okay? And it happens after each stroke. It's in like random areas. It's not just one area that's affected, okay? Frontotemporal, what did we say? We said it's progressive, but it's focal. So only the frontal and temporal areas are affected. We said if the frontal area is more affected, then he'll present with cognition, behavioral changes. If the temporal area is affected more, then they'll present with language problems. صح? Yeah. Okay, what did we say about prions? Let's review prions. What did we say? How would they present? Yeah, they would have spongiform encephalopathy. Yes, that's the key word in prions. You need to remember rapidly progressive, because prions will have dementia, they'll have mental problems as well. They could have, I think they have ataxia too. Let me make sure. But in Muhim, the key word that makes them different is that it's rapidly progressive. Yes, absent immune response. They can have history of consuming contaminated stuff. Exactly. إيش في diseases كمان, which is basically Prince Jacob. Yeah, they can have cerebellar dysfunction. Okay. Frontotemporal, a normal pressure hydrocephalus. This is another cause of dementia, and usually the hint is that when they do the spine, when they do the MRI of the brain, they find the ventricles dilated. Okay, both ventricles very dilated, and when they did the CSF tap, it was normal pressure. Okay. Multi-infarct, we said mainly هذا. Okay, no problem. Does anyone else have any more questions before we go on to the review questions? Okay. Okay, let me do this. Okay, yalla. Read the slides, and then I want someone to unmute or answer, or try to answer على طول if you want عادي. If you don't want to unmute, you can answer directly بالهذا chat. Okay, Afnan, I'll let you know. Let's just read the thing. Okay, you guys have an answer?
Yeah.
Yes. Okay, what do you think the answer is?
So I think it's Huntington's, because when they mentioned that the dad committed suicide, and suicide is one of the major causes of death in Huntington's. Also, the fact that the father had it could indicate that it's genetic. In Huntington's, there's behavioral changes as well towards the
Okay.
Then
What
neutral
other
ankle position after triggering the plantar reflex. This is dystonia, right?
Yeah.
Yeah.
Also, irregular, non-repetitive, and arrhythmic movements. This is the chorea. Yeah. So this is Huntington. Okay. And this is the explanation here. It's a amboss question, as you can see. So I added the explanation here. Okay. طيب. No confusion with this, huh? We'll go to the next one. Okay, يلا. Next person, someone read. If anyone knows the answer, directly عادي unmute or just say the answer بالchat. B. طيب, why B? What made you think of B? Hammer toes and ataxia. Why base gate? Also, yeah. Also his age, it's young. So you know that it's a mutation. Okay. Also glucose level, yeah, it indicates the insulin resistance. Okay. And I added here again the explanation. So it's Friedreich ataxia, okay, which is the most common hereditary ataxia, especially when you see his age and he has ataxia. So you think of Friedreich ataxia. Okay. So wait, let me do this. Okay. Next question. Do any of you know the answer?
Is it D? Generalized cerebral
What?
atrophy?
E?
I think it's D or A. The
D or
hallucinations
A?
were, yeah.
Okay. You're close. Does anyone else want to try? Or do I go? Okay, let's see. Okay, so why do you think it's D or A? What do you think she has? Or yeah, she has.
Alzheimer's, which I believe presents with both at different stages.
طيب, is it, what's her main complaint?
Increased difficulty finding her way back home and
For the last
unable to
several
recall names of relatives.
Right? So last several months indicates that it's more chronic, صح? So now you know it's AD. Okay, so it's not delirium. Delirium, هو it usually presents with hallucinations because it's acute onset and it's acute onset. So it's suddenly she has hallucinations, confusion, doesn't know where she is and all that. Okay, that's delirium. In AD, they don't have hallucinations. They have forgetfulness and all that, and it's usually over several months. Okay? So that's why, yeah, it's generalized cerebral atrophy. Okay, and this is exactly explaining it why. I even added why not A, because I said hallucinations and sudden memory loss, they're caused by delirium. Okay. Although this patient suffers from cognitive impairments, her issues have been subacute. They're not acute. Okay. And B isn't right because B is resting tremor. So she has, that means it's Parkinson. She doesn't really have signs of Parkinson. Okay, she's elderly, she's forgetful. It's Parkinson, remember, they'll have to mention pin rolling tremor. They mention, if they don't mention it, they can give other signs of movement disorders, okay? They wouldn't have dementia this early. They wouldn't present with dementia. The dementia would come later, okay? And yeah, I think that's it. That's all. These are the references that I used. I mainly use Osmosis for Boys and Beyond videos. And if you guys have any questions, let me know. Okay, even if you don't remember them now, you can ask me command later on my email or phone number. Okay, no problem. Can you send your slide? Yeah, I'll send it to Amru, and then he can share with you guys. Okay, and so, guys, no need to tag me, just pray that I get A's in all my exams. Wallah, I enjoy this. Thank you all for actually listening, interacting. Okay, Amru, are you here?
يس روان ثانك يو يعطيك العافية والله يعني البرزنتيشن كانت كثير حلوة ويعني عذبتي حالك شكرا.
No, honestly, I'd love to help. So يعني it's nothing. I just wanted to say I'll send you the presentation, okay?
تمام sure.
Awesome. Thank you guys.
You're welcome.